Good evening, everyone. I am Aparna. I am from CMC Vellore. On behalf of the Society of Chest Imaging and Intervention, I warmly welcome everyone for this webinar. And we are very thankful to Dr. Yvette Kirubha, who is a consultant radiologist in Apollo, Chennai, who has graciously accepted to give us this talk on the different imaging patterns in lung cancer. As we know, when we were in younger, older times, there were only like adenocarcinoma, squamous cell carcinoma, there were only 3-4 types. Now there are so many different types of adenocarcinoma and so many different treatment strategies. So it's important for us to keep abreast with all these changes that is happening. And it is also important for us to recognize these patterns so that we don't mistake them for infections. So we do see now and then that patients are being continuously treated for TB or etc., not realizing that it is malignancy. So it's important for us to realize all this. So it's a good topic that Dr. Yvette has chosen for this webinar.
So we will be looking at lung cancer, the way the different imaging patterns of lung cancer, and why, as Aparna had very crisply summarized, why these are important. Right. So the outline of the seminar is like that. I have prepared this keeping in mind the WHO 2021 revision of lung tumors. So we will be looking at the radiological pattern and the histopathological and the molecular basis is very, very important to be able to understand the radiological pattern. And therefore, we will go through them in little detail. And then we'll quickly look at the pitfalls and mimics, which we most of us are aware of, but we tend to ignore this diagnosis when it for some particular patterns, and we will look at the 3 review cases where you can just try and apply all that you have learned in this. So this is the WHO 2021 revised classification of lung tumors. The broad categories are the epithelial lesion, into which the routine adenocarcinoma, squamous carcinoma, large cell carcinoma, and all these fall into this category. And then you have the neuroendocrine lesions, the carcinoid and the malignant types, which are the small cell and large cell neuroendocrine tumors. Tumors from ectopic tissues, this is very, very, very rarely seen. We were just today discussing how rare it is for this kind of tumors from ectopic tissues in lung. Then mesenchymal tumors, yes, they do occur more common than these ectopic tumors. The common ones that we see are hematoma, the myofibroblastic tumors, and the pleuropulmonary blastoma, especially in children. Children have more of these mesenchymal tumors. And then you have this hematolymphoid malignancies again, lymphoma and all these other hematolymphoid malignancies are more or less systemic conditions, and you will get to see lung involvement either primarily or as secondarily. So what is the rationale behind all these changes? Now, initially it used to be purely the morphology, whether it was a squamous or an adenocarcinoma. Then came in the immunohistochemistry, especially in poorly defined carcinomas. They found it difficult to differentiate between whether it was squamous or adeno or large cell and so on. So immunohistochemistry definitely played a role, where there were a lot of markers to find out which kind of tumor was it. And then over last 7-8 years, maybe from 2015 onwards, the emphasis has more into molecular analysis. As we know, the EGFR, the KRAS, ALK translocations, and so on. So this is the reason why we are getting more and more revision. And so if you want to understand the 2021 classification, you will have to go behind for the first major change that was introduced in 2011 by the IASLC and the ATS and ESR. Okay, so the major change at that point was the reclassification or the renaming of adenocarcinoma, where it was divided into the precursors and then the invasive lesion. We will look at all these things in detail. But crisply summarizing the 2021 major changes, the T staging is dependent on the invasive component, that is a solid component of the lipidic non-mucinous adenocarcinoma. So we will, in order to understand all this, we have to go back and get to know what these terms are. So we will look at them in detail. Then we know lymphatic, vascular, and so on invasions, but the new recently accepted way of invasion is spread through air spaces, otherwise known as STAS, STAS, STAS. Okay. And then there are newer endocrine concepts. It is not a simple transition from a carcinoid to a small cell carcinoma. The genesis itself is very different. So there are newer endocrine concepts. And of course, as always, a few new tumors have been identified and introduced. So why we need to know all this? That is important. As Aparna explained before, we have so many mimics. The thing is, many of the pathologies like TB or sarcoid can mimic lung cancer, and lung cancer can mimic all these. So it's both ways. Okay. So that is why it is important to recognize that can this be a lung cancer? Now, more and more women are getting diagnosed with lung cancer, rather than it was not a simple smoking pattern and a squamous cell pattern. As you know, it's more of adenocarcinoma pattern, non-smokers, younger age group. We saw somebody as young as 30. So the younger age group with lung cancer and so on. So we do not want to miss out an early cancer because the pattern was different. Okay. So keep that in mind. Do not label everything. Tendencies to call, as Aparna said, everything as TB or, something like that. Or infection, any ground glass, okay, this is some infection sequel. No. So we'll have to be able to recognize and tune our eyes, and at the back of the mind think, can this be lung cancer? In the today's situation, I think that is very, very, very important, because we tend to overlook. And another important thing why you need to know is the staging. The staging is very, very important, because sometimes lung cancer can be multiple cancers, multifocal cancers, and so on. So the staging becomes very different. If it's a single lesion, like in near the hilum, or it's a single nodule in it's an adenocarcinoma, the classical kind with the peripheral spiculate nodule, then it is easy to stage. That is just one pattern. Then you have the other pattern where there are multiple lung cancers, and if they are of different histological subtype, you have to stage them separately. Okay, so that is another important thing you need to be able to recognize. If the histological pattern is different, then separate staging. Then if you have this multifocal adenocarcinoma, like if it both lungs, if there are ground glass opacities and consolidation, now that also you'll have to consider a different type of staging for that based on the dominant lesion, and then you have the M and N and M, and different kind of staging for that. Or if there are multiple solid nodules, then the T staging becomes based on the size of the largest lesion, and then you put the number of lesions in the bracket in the T staging itself. It doesn't directly become metastasis. Okay, so there are implications for staging based on the pattern. So you need to know the patterns in order to be able to stage accurately and therefore guide therapy. So when it becomes a multifocal lung cancer, multiple lung cancer, then there is a possibility of doing resection. Or if it is becoming metastasis, then the therapy is very different. Then you have to start doing giving systemic therapy. So that is why it is important. Of course, it is all dependent on the pathology, but before that, you could definitely, we have a great role in guiding what has to be done for the patient. And of course, currently you have this immunotherapy and the drugs against the molecular molecular drivers. So for instance, immunotherapy, PD-L1 is a target. So there are a lot of drugs acting against that, and the response is quite good. Then for instance, EGFR, you have the tyrosine kinase inhibitor. So those are the drugs which could produce very good response. So there are a lot of if you can find out imaging biomarkers for these kind of molecular changes, then it is good. So this is what we are moving towards that. Okay, so that is why we need to be able to recognize the patterns of lung cancer. Just a quick for the want of time, I'm just saying that this is all something which you know. But the trend now, as I said, is changing. It's more women, non-smokers, younger patients who are getting lung cancers, and there are multiple lung cancers. So this is something you have to keep in mind. The trend also has changed. Even in India, it has changed from squamous cell carcinoma to adenocarcinoma. These are Indian statistics. So you can see that adenocarcinoma is the dominant type. Therefore, the squamous cell, non-squamous, the small cell, and all those patterns are quite what to say, homogeneous and easy to identify. But this adenocarcinoma is the one which causes a lot of trouble because of the way it presents. So we should be able to recognize the plethora of patterns that are available with that can adenocarcinoma can present with. Okay, so I remember this is the most commonest subtype in India too now. So these are the other carcinomas. And then the presence of EGFR mutation, that is quite common, and ALK rearrangements also quite common in our country. So this was a broad, can you see my cursor? I don't know if you can see my cursor. Okay, so
Yes, ma'am.
you can see the cursor. Thank you very much. So you know that based on the cell type, broadly it is divided into non-small cell cancer and the small cell cancer, which is a neuroendocrine origin. Okay, so we will look at all those in detail, and then there is the non-small cell lung cancer, which is divided into adenocarcinoma, squamous cell carcinoma, and the large cell carcinoma. So this adenocarcinoma, we look at it, spend some time looking at it in more detail. Now that is divided into the precursor lesions. There is an in-between minimally invasive stage, and then there is the invasive adenocarcinoma. The precursor lesions are the atypical adenomatous hyperplasia and the adenocarcinoma in situ. These are the two precursor lesions. There is an in-between which is known as a minimally invasive adenocarcinoma. We look at the criteria for all of these, and then you have the invasive adenocarcinoma. The invasive adenocarcinoma is, again, there are two types. So the pathologist will be calling it like this only. So there is the non-mucinous type and the mucinous type. So the non-mucinous type, the histological cells are, the histological variants are the lipidic type, SNR type, papillary, micropapillary, or a solid type with mucin or without mucin. Then the non-mucinous type are the colloid, fetal, and enteric. This is the columnar cell origin. Okay, so remember, invasive is divided into the non-mucinous and the mucinous. Why this is important? We'll look at it, because all of these have implications for the imaging patterns that you're seeing. So once you understand the behavior, then it becomes easy to correlate the imaging patterns and to think, can it be a cancer in the appropriate setting? Right. So this is a common terminology used nowadays. If you are new to radiology, and this is we never heard this term. For us, it used to be bronchoalveolar carcinoma. Now, that is an obsolete term. From 2008 onwards, it has been suggested not to use the term. So bronchoalveolar carcinoma is no longer an accepted terminology. So what does lipidic pattern mean? It means that there is growth along existing alveolar structures only. Now, that is just ditto copy paste definition. Okay, so growth along existing alveolar structures only. Now I'll explain what is difference between spread through air spaces little later, but let's look at this patterns now that we defined what lipidic pattern is. Okay, now this is a spectrum of lesions. The first two, AAH and AIS, are precursors. MIA is in between, and then there is the invasive adenocarcinoma. So this diagram is lifted from this article, but I made my own creation to it to try to explain. So atypical adenomatous hyperplasia, this is the alveolar cells. There is the structure all, then this is the stroma. So the cells here, the type 2 cells, some degree of adenomatous change is happening. It will be usually 5 millimeter. Okay, so that is atypical adenomatous hyperplasia. 5 millimeter, no invasion, it is just sitting on the surface like that. It may progress, may not progress. Mostly it is very, very indolent. Okay, so the next one, adenocarcinoma in situ. Now what happens, it looks exactly similar like this, but instead of just limiting itself to one particular area, it is going around little more area, so up to 3 centimeter. Okay, so and it is not invading anything, it is just seen on the surface of the existing alveolar structure. Okay, it's growing along the existing alveolar structure. So anywhere between 5 to 3 mm is adenocarcinoma in situ, right? So another, what is this minimally invasive adenocarcinoma? Suppose this spread along the surface is a lipidic component. Now, if the lipidic component develops another component which is solid, what happens is the solid means it can be SNR, papillary, micropapillary, and all that, apart from the lipidic. So there is this lipidic component, and apart from that, one solid thing develops. That goes through either the basement membrane, okay, the myofibroblastic stroma, or crosses and invades up to 5 millimeter. Okay, so that becomes minimally invasive. So there is a lipidic component, there is a small solid component which is either going through beyond the surface of the alveoli or up to 5 millimeter. Okay, so the lipidic component does not do that. It's only the solid component which invades. That is known as minimally invasive adenocarcinoma. So that also can be between 5 to 3 centimeter. By definition, anything more than 3 centimeter, any lesion, nodule, mass more than 3 centimeter, it is invasive. So it will no longer be precursor lesions, but it will rather become invasive lesion for an adenocarcinoma. So one of the criteria is size. Then what happens is there is the lipidic component, and then there is also the solid component. Okay. There is also the solid component which goes beyond the myofibroblastic stroma and is more than 5 mm invasion, and it starts invading the blood vessels or the lymphatics, and also there may be spread through air spaces. That is, it gives evidence of invasion, lymphatic invasion or vascular invasion or air space spread. Okay, so this is invasive. In minimally invasive, it may go through the myofibroblastic stroma, but it does not involve vascular, air space or lymphatic invasion, and it is limited to less than 5 mm. More than 5 mm and all the other invasion, it becomes invasive adenocarcinoma. Understood? I hope this is clear. Once you understand this, then it becomes easy to understand the patterns. Spread through air spaces, however, is not going like this, but rather within the alveoli, clumps and clumps of spread will be spreading. It can occur with any tumor type, not just lipidic. Okay, so you can have a solid mucinous, non-mucinous adenocarcinoma invasive, which can have spread through air spaces. So do not confuse these two patterns. Lipidic is different. This is different. Right. So now we looked at all this precursor lesion, minimally invasive, and this is just this is a nice table which just summarizes how the pathology, the radiological features happen. So atypical adenomatous hyperplasia, I said it. So because it just goes through all along the surface like a lipidic pattern, it will just be a ground glass nodule. The size component is 5 millimeter. Okay, usually 5 millimeter or less. AIS is 5 to 30 millimeter. Usually it will be ground glass nodule, or it may have a part solid component. Okay, now that is all. I'll explain why it is all ground glass density. Minimally invasive, same, part solid and a solid component which is less than 5 millimeter. So when you're staging, what you actually measure for a part solid nodule is the solid component size, which you have to measure and stage, not the entire ground glass, but the solid component in the ground glass. Okay, so that is minimally invasive. The solid component has to be less than 5 millimeter. And an invasive adenocarcinoma, you know that the solid component is more than 5 millimeter. Okay, so I'll explain invasive adenocarcinoma, how it is differentiated in the next slide. So you understood this. Okay, so ground glass, part solid or ground glass, MIA is there will be a solid component, and then invasive adenocarcinoma, a solid component that is greater than 5 millimeter. So this is very important. Like I said, this bronchoalveolar carcinoma is no longer used. These are the things for which it was used before. Before we go into the other imaging patterns, like I just like to reiterate the definitions. I hope you're all familiar. Pure ground glass nodule is a focal area of increased lung attenuation. Nodule is anything less than 3 centimeters, in which the margins of the structures remain outlined. Okay, same thing like consolidation, ground glass, we say, no, same thing. The margins of the structure remain outlined. Solid nodules, the margins of any normal structure will be completely obscured, but it's a nodule. Then part solid is it has both solid and the ground glass component. That is part solid. Subsolid nodule includes both pure ground glass nodule or a part solid nodules. Wherever there's ground glass, that comes under subsolid nodule. So this is an example of a patient who has a nodule in the right upper lobe apical segment. You can see that there is a ground glass component, and then there is a solid component with surrounding ground glass in the same lesion. So you have to measure actually the solid component. So this is a part solid nodule. This is an example of a part solid nodule. Biopsy of this turned out to be adenocarcinoma in situ. Now, if you don't resect, it depends on where you biopsy it. It may have invasive cancer also, but biopsy turned out to be adenocarcinoma in situ. Okay, so this is a part solid nodule. Right. So coming to the imaging pattern. So when you have nodules, which are less than 3 centimeter, what are the things you should think of? If it is a pure ground glass nodule, it can be single or multiple. If it is less than 5 millimeter, you can think of, I'm talking in relation to cancers alone. Okay. You can think of atypical adenomatous hyperplasia. Up to 3 mm, 3 centimeters, slightly larger, you can think of atypical, adenocarcinoma in situ. Or you can think of a lipidic predominant adenocarcinoma. I'll let you know what is a lipidic predominant adenocarcinoma in just a few slides. Okay, so these are the differentials you can think of when it's a pure ground glass nodule. When it is solid, it can either be single or multiple. Invasive non-mucinous adenocarcinoma is the most common histological subtype which produces solid nodules. Less commonly, mucinous adenocarcinoma. Non-mucinous invasive adenocarcinoma is the one which produces solid nodules most commonly. And remember, 25%, quarter of them can be solid nodules, can be due to squamous cell carcinoma. Let's say 75% is due to adenocarcinoma. I mean, there will be other, or say let's 60% due to adenocarcinoma, and at least a quarter of them is due to squamous cell carcinoma when you have a nodule pattern. So when you have a part solute, that is where is a ground glass component as well as a solid component in this, if the solid component is less than 5 mm, okay, the entire thing should be only 3 mm, but the solid component is less than 5 millimeter, then you can think of minimally invasive adenocarcinoma, or part solid appearance can also be due to lipidic predominant adenocarcinoma. Right. So we looked at the precursor lesions, and a word about this invasive adenocarcinoma, non-mucinous invasive adenocarcinoma, how it can present. So we will look at the invasive adenocarcinoma non-mucinous type. That is divided again into the lipidic predominant adenocarcinoma or the others, like depending on the cell type, SNR, papillary, and so on. So this lipidic predominant adenocarcinoma usually it presents as it can present as a nodule. Like as I said before, it can present as just a pure ground glass nodule or solid, or it can be mixed. It can also present as just an extensive lobar ground glass opacity. Okay, that is one important pattern. Extensive lobar ground glass opacity. It can have bubbly appearance, that is known as pseudocavitation, air bubbles kind of picture within it, that is pseudocavitation. And if it develops, it will have a solid area, and that is the invasive component. So what do we mean by this lipidic predominant adenocarcinoma means? So there is lipidic spread along the surface, okay, but there is a small solid component. So the dominant component is only a lipidic type of spread. The solid component is very minor. Therefore, it can have solid areas as well as the ground glass. Now, if you see, this is the alveoli. Let's presume this is a caricature of mine. If you presume this is alveoli and these are the tumor cells, this lipidic thing will go all along the structure of the alveolus only. So what happens, most of the air is still there, and therefore you will get a very low attenuation. It is not like a solid completely, so you get a ground glass type of pattern. That is why this lipidic most often presents as a semi-solid or a ground glass kind of attenuation. Whereas the other invasive non-mucinous adenocarcinomas are quite invasive, larger cells. They break through the alveoli. They don't limit themselves to the alveoli. They form huge clumps like that. So therefore, this presents as solid nodule. Okay, so that is why the appearance is different. The others can present as predominantly solid or a mixed mass, depending on the degree of lipidic spread they're having. And then some of the main clues that will give you an idea that this nodule is malignant will be, apart from your speculation, coarse septal and thickening and all that, pleural retraction. If it is attached to the pleura, it will retract, and then surface notches. Now again, in India, it's a problem. I don't know if how many people have studied, but in India, TB can use exactly the same thing. So keep that in mind. A very common mimic is TB. So then you have this vascular convergence sign where the vessels are pulled towards the nodule, and then you have what is known as a consolidation to tumor ratio. You measure the solid area to the consolidation. The more the solid component, the bad the prognosis, because that is going to be the more invasive one. The lipidic spread is a very indolent, slow growing process, whereas the tumor solid area is the one which will determine the prognosis. That is why we measure the solid area also even on staging. Okay, so this tumor to consolidation ratio is also very important. So this was about non-mucinous invasive adenocarcinoma. So we have this patient who's just remember 36-year-old female. Okay, so non-smoker female. You have the speculate mass, and this was an adenocarcinoma with lipidic spread. It is not a lipidic predominant because it's extensively solid, but there is a lipidic component towards this. You can see the speculation, and you can see the vessels are converging towards the mass lesion. So this is a vascular convergence, and this is another patient who has extensive consolidation ground glass in both lungs, and you can see multiple bubbly areas within it. So this is a pseudocavitation or the pseudocavitation that can occur within a lipidic predominant or any form of invasive adenocarcinoma, and this was predominantly SNR pattern, not lipidic pattern. Okay, so this is pseudocavitation. Then this is another patient. You can see multiple nodules. Both lungs have multiple nodules. Some of them are pleural based, and you can see the pleura is getting distorted here. Okay, so this is a pleural retraction you can see, and this turned out to be SNR adenocarcinoma, solid nodules. Okay, so SNR adenocarcinoma from lung. Right. So that was about non-mucinous. We will look at the imaging patterns of mucinous invasive adenocarcinoma. So what happens here is this is the alveolar cells. This is the tumor cells. What in mucinous, the cells are less, but lot of mucin is produced, which replaces the alveoli, the air in the alveoli. Therefore, you start to get air bronchograms and angiogram, CT angiogram sign. Okay, so whenever there is consolidation, consolidation is air getting replaced in the alveolus, in the air containing structures by either fluid or cells or any kind of mucin and so on. So in this, the cells are less, but lot of mucin is produced. Characteristically, the patient coughs up lot of sputum. So this mucin is produced. So therefore, you get air bronchograms and CT angiogram. Here you can see this is a CT angiogram sign, like consolidation and the vessel going through. The same thing you can get in pneumonia also. But same thing you can get in mucinous adenocarcinoma also. This is the reason why you're getting these signs. Whereas in the non-mucinous adenocarcinoma, this is the cells which are replacing it entirely. So what happens? The bronchus gets destroyed or invaded, and the vessel also gets invaded or caught in between. You don't get a nice air bronchogram or a angiogram like how it would if there was fluid within the alveoli. Okay, the cells, and this is invasive and they destroy. So remember this, mucin fills up the air spaces. Therefore, you get the presentation is like a consolidation with air bronchograms. Mucin is almost like muscle density, slightly lower than muscle density. This is the presentation of a mucinous adenocarcinoma. You could get nodules or ground glass opacivation or a combination of all this. But when you see nice homogeneous low attenuation lesion, consolidation area with air bronchogram, CT angiogram, and it is bulging the fissures and there are some surrounding nodules, then think in mind, especially if the patient does not have features of infection, then think in mind, can this be a invasive mucinous adenocarcinoma? Okay. So that is why this pneumonia-like presentation is important. We should be able to recognize pneumonia-like presentation of lung cancer. So the commonest histological type which will produce this is an invasive mucinous adenocarcinoma, and I told you why. So this consolidation pneumonia-like thing can either be single or multifocal. It can be both lungs, multiple areas in a lobe, or multiple lobes, and so on. So there is some distinction between the types, the morphological types and the radiological patterns. If it is localized type of consolidation to less than 50% of one lobe, it is not usually mucinous, but rather it becomes an acinar predominant. But if it is multiple areas of consolidation, it's more likely to be invasive mucinous adenocarcinoma. Like you can see that this kind of multifocal pattern is more common in male smokers, and the WBC and CRP is increased. It's looking more like infection sometimes. Very closely it mimics infection. The other one does not. Okay, the clue will be the bulging fissures. It's like expanding, so that is one thing. Then presence of big nodes. Infection can produce nodes, but these nodes will be much larger. Presence of septal thickening and some kind of adjacent nodes, and a large effusion or a pleural thickening which is nodular. So those are the features which will help you decide that this could be a pneumonia. And any pneumonia which is not resolving 2 to 3 weeks, or if it keeps occurring in the same place, that needs to be investigated further to rule out an underlying malignancy. Right. Thanks to Aparna for this case. Even in the last minute, she was so helpful in sending this case. So you can see this patient has a beautiful lobar consolidation limited by the fissure, lower lobe. And then you can see that there is effusion also. This was in May and this was in August. You can actually see the air bronchograms inside those the area of consolidation. It is more or less static. It's not resolved. It should have 3 months with therapy. It should show some degree of change. It is looking same, or in fact, maybe it is slightly more, I don't know. But this warrants definitely investigation and biopsy. And you can see this is the corresponding CT. You can see air bronchogram and CT angiogram. And the histopathology, this showed a mucinous adenocarcinoma with a lipidic pattern. Okay, so this is a classical example. See, you can also see the note that the fissures are bulging. It is not concave. It's a nice bulging fissure. Entire thing is homogeneously consolidated. So this is an example of a mucinous adenocarcinoma. Yeah, so just to summarize the difference between mucinous and non-mucinous. Okay, so yeah, so if it's smokers, looks more or less similar. Mucinous will produce consolidation with air bronchogram, whereas non-mucinous is either a nodule or a ground glass attenuation. Mucinous is multifocal sometimes. This is not so much, but non-mucinous will produce spread through air spaces quite commonly. Okay, whereas mucinous is just like it will spread along the mucin and fluid, whereas this one will get clusters along the airway. It will go. So, yeah. So this is again an example of an almost entire lobar ground glass. So you could think of something like a lipidic or a combination. Okay, so this is a non-mucinous, whereas this is, you can see consolidation, ground glass nodules, and a lot of ground glass and some air bronchogram features. So this is an invasive mucinous adenocarcinoma. How to differentiate between lung infection and a localized consolidation, which may be cancer? Now, there are no hard and fast rules. You might have to consider PET, or you might have to discuss and then consider a biopsy. There's a lot of confounding factors, but you can generally remember that bulging, those things are worrying. Pleural retraction and the vessels pulling through it, all these are helpful to decide that it could be a cancer. And whereas a smooth pleura and satellite small nodules, ground glass, bronchial wall thickening, all these can favor a pulmonary infection. Now you can get air within lung cancer, okay, or a nodule or a consolidation in the lung. In that case, what are the things you should think of? Air within a nodule or an area of consolidation. Now, in infection, what happens is air is due to abscess formation and it occurs quite early. Okay, but in a nodule which is squamous cell carcinoma, the cavitation is due to ischemia. It is outgrowing the blood supply, so it has to be a large nodule for it to develop cavitation within. Okay, so it comes little later. So that is squamous cell carcinoma. Pseudo cavitation, you know, I just described, no, adenocarcinoma with multiple small air lucencies within. So that is pseudo cavitation favoring adenocarcinoma. Then you have one entity known as lung carcinomas associated with cystic aspaces, which I will explain to you in the next slide. So remember, infection can have air and abscess formation or a cavitation in squamous cell carcinoma, pseudocavitation in adenocarcinoma, and carcinomas associated with cystic aspaces. So what is this lung cancer associated with cystic aspaces? Normally we think bulla doesn't matter. Usually we used to dismiss all this before as some inflammatory infectious sequelae and all that. But it has found that this is forms nearly 22% of missed lung cancers. Okay. And it's very important therefore to be able to recognize this pattern in order not to miss an early lung cancer. Usually adenocarcinoma, but it can be squamous or any other histological type only. Okay, so what is a cystic aspace? It's a round parenchymal lucency with well-defined lung interface and a wall less than 2 millimeter, and there should be no emphysema, without emphysema. So this is a criteria. And these are the 4 patterns in which you can get. So there is an exophytic nodule. There is a cystic airspace and an exophytic nodule. That's type 1. There is a cystic airspace and an endophytic nodule. That is type 2. And then you have an irregular wall thickening, you know, kind of crumpled, that is type 3. And then you have this multiple cyst and center one nodule develops, that is the type 4. Okay, so these are the 4 different types of lung cancers associated with cystic airspaces. So keep this in mind. This also can be a manifestation most commonly of lung adenocarcinoma. Okay, now this is one patient who came to us who they were planning to do a CABG. Now before that lung chest x-ray showed something. So you can see that there is a well-defined spiculate pattern and in the right lung apex. The PET CT was done. This showed uptake, and this was biopsied. It turned out to be an invasive adenocarcinoma. Now, what I would like you to notice is this lesion. Okay, this is a cystic airspace, but you can see the wall is so eccentrically thick and there are some speculations around it. Now, there is a high possibility that this could be also an adenocarcinoma. A PET uptake did not take place on this. Okay, now that is because it is such a small thing. So the size also matters for PET. So this has to be in follow-up to see that if this is a second lung adenocarcinoma. So this, if this is lung adenocarcinoma, lung cancer, it will belong to the type 3. You know, this pattern of the interesting thing is we did the MRI for this patient, and we found that this part of the wall was actually showing nice diffusion restriction. So that makes it even more worrisome. Okay, that was about nodules. Right. So mass is anything more than 3 centimeters. So what are the lesions which can, now after this it's going to be very easy, what you have all know before, and it's just a quick revision of that. Okay, this adenocarcinoma is the main troubling part. So mass is anything which is more than 3 centimeters. The most common again is an adenocarcinoma. It can be peripheral or it can present as a central mass also. And squamous cell carcinoma is usually a central mass. Large cell lymphoma, again a necrotic mass, it can be peripheral. Then lymphoma can present as mass. Carcinoid can present as mass. Right. So you can see that here there is a lobulated lesion. Here also multiple nodes are also there. So this could either be squamous or an adenocarcinoma. This came as poorly differentiated carcinoma. This is a peripheral adenocarcinoma. You can see that septal thickening and multiple nodules are also there, especially this lobulated nodular pleural thickening that is more common with an adenocarcinoma. Then there can be a presentation where there is extensive mediastinal adenopathy, but you can't see a very clear mass. It's all bulging into the lungs, but where the node ends and where the mass ends, you can't really say. And where is the mass is a question mark for you. Now, that kind of appearance is most common with small cell lung carcinoma, okay, or a very poorly differentiated adenocarcinoma. Rarely does squamous cell carcinoma produce that extensive adenopathy. So it is usually a small cell carcinoma or a poorly differentiated adenocarcinoma. Here you can see that there is consolidation, some different enhancement, lot of nodes, but where the hilar nodes end and where the mass ends is really difficult to say. You could try applying the mass lung interface sign, where you, if you see that the edge is very spiculated, irregular, and the some edge between the mass and the, if that interface is irregular with spiculation, then you could think that this could be originating from the lung and not a purely mediastinal just nodes. Okay, so that is possible, but as for everything, most of the times you cannot apply this very clearly. So that kind of an appearance, visible adenopathy with, diffuse adenopathy with no visible mass, small cell cancer, poorly different, and of course lymphoma can do this. Keep lymphoma also in mind, okay, because that will produce diffuse adenopathy. A word about multiple lung cancers. They are can occur in 8 to 22% of the times. By definition, there should be same pathologies, and there should be carcinoma. It should be carcinoma in situ, no lymph node involvement, and no extrathoracic metastasis to call it multiple, right? For instance, if you're saying multiple adenocarcinomas, it has to be adenocarcinoma same type, and it should be in situ, no lymph node involvement, and no extrathoracic metastasis. You can have synchronous cancers or metachronous cancers. The patient having a lung cancer and cancer somewhere else also. Two different histological subtypes in lung cancer in the same patient, so on. So there are different combinations for multiple lung cancers. Very sometimes very confusing how to manage all those things, how to understand. So that is why an MDT is very, 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 very important to it's sometimes the radiologist alone cannot solve these things. So an MDT makes a lot of help, and the radiologist's role is to be able to identify all this and stage it appropriately. So usually multiple lung cancers can be present as 1 to 3 centimeter multiple nodules. They can be solid nodules or it can be ground glass nodules. They can present as multifocal GGOs or multiple consolidation. I just told you about multiple pneumonic consolidation appearance type due to mucinous invasive adenocarcinoma. Again, this multiple thing is usually due to adenocarcinoma. This is the most troublesome one. And when they are multiple, you try to see if they are same histology or different. Like, can one be a squamous cell and one be an adeno, if possible? But a lot of times, no, you can't. So when they are multiple, you measure the dominant lesion. That is the biggest lesion. There may be two lesions, one lesion big, but it may contain more ground glass. You are not to consider that as a dominant lesion. The lesion with the largest solid component. Okay, now that only you should measure and consider it as dominant lesion. Okay, so when you have things like this, how do you differentiate between metastasis and lung cancer? Again, very, very difficult. But some things are subsolid nodules, that is mixed ground glass attenuation nodules, are rarely metastasis, very rarely. Okay, and then basal smooth lung interface, presence of feeding vessels in peripheral, those are the things which favor a metastasis more than multiple lung cancers. Even on histopathology, it becomes very difficult. Even today, we just saw a patient who has multiple lung nodules, ground glass and solid, with PET uptake, and the PET also shows a segment of rectum showing uptake. So biopsy was mucinous carcinoma of the rectum. Lung also came as mucinous carcinoma of the rectum. So is this metastasis or is it synchronous primaries? Now that is difficult. We tend to assume that, okay, there is a primary, so this will be metastasis, but need not always so. So the only way to do it is the clonal typing and the molecular typing and so on to differentiate. But remember, multiple lung cancers is up to 1/4 where it can present. So keep that in mind. Now, this is an interesting story of a 76-year-old gentleman who presented in 2020. That was COVID at its peak. during I think, I don't know, September or October or something like that. 76, breathless, saturations dropping and all that. So immediately COVID comes to mind. When you see a picture like this, multiple peripheral consolidations. 3 times they repeated COVID, RT-PCR and all those investigations. All the time it came negative. Okay, then they considered, can it be BOOP, or should be consider it as some form of ILD, or what is it? They kept on chasing it, and finally after MDT discussion, they did a PET. You can see all the lesions, multifocal consolidations are there involving almost all lobes. They're all lighting up on PET, and finally when biopsy turned as adenocarcinoma. So this is multifocal adenocarcinoma. So easily it was mistaken as COVID. A lot of time was wasted as thinking as COVID. This is another multifocal adenocarcinoma, with the nodular appearance. Some of them are cavitating, some of them are ground glass, many of them are solid. And then the main thing is you see a spiculate irregular lesion which is touching the pleura here in the lingula, and some air foci within it. So this is a dominant lesion. So when you stage it, you will measure the solid component of this lesion for the T, use it for staging, and then you'll put M in the bracket, meaning multiple. No, so this is how you will stage it for a multifocal lung cancer. A word about the imaging biomarkers. Aparna, how much time do we have? Sorry. Okay, a word about imaging biomarkers. So EGFR is quite common. ALK rearrange, these are quite common mutations that can happen. So you should know that for EGFR mainly it is ground glass or air bronchograms, and it's a female non-spoker kind of profile. So this is the one which produces multifocal involvement also. The worst one is this MET exon skipping that has a sarcomatoid variant also. So this is really bad. And the ALK and ROS have high rates of brain metastasis. Okay, so this is a MET exon 14 skipping mutation. Both of these are females. So this is a 60-year-old lady, solid nodule, a rim of actually it's dilated bronchi all around it, and then some ground glass and speculations. So this was she underwent complete resection, and it is PD-L1 positive, so immunotherapy is positive, and then there was STAS positive also. So probably this ground glass is due to spread through airways, and this is the large solid component. This is also another female in 55-year-old. You can see a necrotic malignancy in the lung, extensive nodular pleural thickening. By the time the diagnosis was over, this lady actually passed away. It was so bad, and she had sarcomatoid features. So that was about adenocarcinoma and the biomarkers. So quickly a word about the other tumor types we can go through. So there is a squamous cell carcinoma, you all know. It's a central mass. Here you can see it's filling the entire bronchus, causing the entire lobar consolidation and then collapse, and then there is effusion also. The pancoast is the pleural invasion in the apex. It can also present as a spiculate peripheral nodule, and it can be necrotic, including the adenopathy. Neuroendocrine tumors, they also have precursors, which is known as dipnec, small air nodules, but they will have air trapping associated with it. Then you have the carcinoid, which is a low grade. Then you have the high grade, which is a small cell neuroendocrine tumor or a large cell neuroendocrine tumor. Carcinoid, you all know it is a very, here you can see it's a female patient, I think 35-year-old, a well-defined endobronchial lesion which shows avid enhancement, and then you can see distal atelectasis. It may have calcification in 1/3 of the patients. That is a typical carcinoid. Atypical is slightly larger and slightly older age group. And in neuroendocrine tumors, the worst prognosis one is small cell carcinoma. Now that produces extensive adenopathy without you can't see a usual primary lesion mass, as I told you before. So what happens is the nodes are really low attenuation, confluent, and they spread around the mediastinum, encasing the vessels. And you can see here the pulmonary artery is so narrowed out, no plane with the aorta. In fact, the bronchus also was completely so narrowed that the lungs started collapsing. Okay, so this kind of extensive adenopathy and no discernible mass, it's encasing and compressing everything. Then you can think of here you can see the bronchus is so narrowed, therefore the lung is cut off. It added squamous cell carcinoma with adenopathy means it will invade the bronchus. Now this is from outside, narrowing, compressing, and causing collapse. Okay. a word about lymphoma, you know, primary, secondary. Primary lymphomas, mucosa associated, malt lymphomas. Most commonly, they present with nodules, multiple nodules, sometimes consolidation, masses, round glass opacities, or a lymphangitis carcinomata kind of appearance. Just like to mention the general teaching, which you have to always hold good is lymphoma does not cause necrosis, but large cell, diffuse large cell lymphoma or a high grade lymphoma can have necrosis and cavitation. Okay, so keep that in mind. This is the various ways lymphoma can present, and it very commonly adenocarcinoma mimics lymphoma. So this is an interesting case of a 45-year-old male who had increasing breathlessness over 3 months. You can see some kind of smooth septal thickening, pleural effusion, multiple small nodules, some nodes, and almost like a lymphangitis type of presentation. Okay, there's a wedge-shaped consolidation here. There is hepatosplenomegaly, but the main clue here is, if you see closely, he's got multiple small soft tissue subcutaneous plain nodules. So what do you think it can be? It turned out to be a T cell cutaneous lymphoma with lung involvement. It is like a lymphangitic spread. So that was the clue in this patient. So this is a T cell lymphoma with lymphangitic pattern of spread. Right. So that was about the patterns. As I again told you before, tuberculosis, pneumonia, cryptogenic organized pneumonia, sarcoidosis, infarct, scar, all these things can mimic a lung cancer, and lung cancer also can mimic all these things. So this was a patient, they thought maybe it is a mass lung cancer nodule, solid, some small bronchi going within, it was persistent. So they went and biopsied it, but this turned out to be cryptogenic organizing pneumonia. So you should keep that in mind. Many of these conditions warrant biopsy. What are the newer things recently introduced in 2021? Actually, this nut carcinoma, midline nut carcinoma is not new, but I thought I'll just create an awareness. This is something related to testis protein. And midline nut carcinomas is usually occurs in the head and neck cancer, but you can also get primary midline nut carcinoma of the lung. Interesting thing about this, it produces extensive adenopathy, which compresses some of the structures, and the central mass, which enhances pleural effusion. But the most characteristic thing is that it all produces only on the one side. Usually it does not go to the opposite side at all, midline and towards one side only. Though it is midline, it does not go to the other side, but only one side only. So this is happening in younger patients. And the other one newly introduced entity actually is SMARCA4 deficient undifferentiated tumor. So it is more like a sarcoma with a rhabdoid variation. SMARCA4 deficient undifferentiated tumor, extensive necrotic nodes compressing in the mediastinum, compressing and encasing all the vasculature. Very poor prognosis. You can have multifocal lesions also involving simultaneously, they can be there in the abdomen and so on. So it's a very poor prognosis lesion. This is in a younger patient, again with extensive smokers. So this is this lesion is there. Then among the benign lesions, this bronchial adenoma or a ciliated muconodular papillary tumor of the lung, that's called as BA bar CMPT. That is a new entity. It can be a central lesion or it can be a peripheral lesion. Most of the time it presents either as a ground glass nodule, but it will have a pleural contact. That helps to raise the possibility, can this be a bronchial adenoma CMPT type? It's 5 millimeter, or sometimes it can be slightly larger also, 1 centimeter and so on, but it can have a pleural contact. Okay, this is nice article which gives you an idea about the reporting template extensively. If you want, you can have a look at it. What are the things you must report when you're doing lung cancer? There are different guidelines. The Fleischner's guidelines for incidental lung nodules. So many guidelines are there. So you can have a look at them and decide how to go about things. Right. So just to conclude, if you have adenopathy with or without a visible mass, then you can think of adenocarcinoma, small cell carcinoma, or lymphoma. These are the various presentations. Then you have a central mass, think of a small cell carcinoma or a squamous cell carcinoma. Cavitation, same squamous cell carcinoma, pseudocavitation, adenocarcinoma. There's an endoluminal component, think of carcinoid. There's a peripheral mass or nodule, again, adenocarcinoma, small cell carcinoma, or a large cell carcinoma. Pure ground glass, it can be precursors, adenocarcinoma, or a bronchial adenoma. A pneumonia-like presentation usually is due to adenocarcinoma or a lymphoma. Multifocal nodules, consolidation, ground glass, again, most commonly adenocarcinoma. And airspace associated, cystic airspace associated pattern is most commonly adenocarcinoma. I don't know if there are 10 patterns, it's a Dasavatar or more, but just keep in mind the plethora of appearances that the lung cancer can present as. Do we have time to go through 3 questions, review questions?
Yes, Dr. Yvette, surely I think quickly we can go through.
Yeah, just 3 cases I have. Okay, will they be able to type in? How can we do it, Aparna?
Yeah, maybe we won't spend too much time, but maybe 10 seconds.
Shall I discuss it? Do they want to type in their answers or?
Yeah, you can give 10 seconds.
Oh, right. So you can, this is a 43-year-old lady who presented, she had a history of mucoepidermal carcinoma of the retromolar trigone. So during evaluation of that PET CT was done and there was this nodule of size 6 mm which had PET uptake. So what are the things you could think of? What are the differentials you can consider?
Someone has written metastasis.
Just put in your thoughts so we can discuss it.
Synchronous tumor is another thought that is coming up.
Okay, yes, the first thing that comes to mind is a metastasis. 6-month follow, 3-month follow-up, I think that was, it was stable. So it was not growing. There were no other features of metastasis anywhere else. So this thing remained just like that. So I think that makes it less likely. Again, it was not basal. There were no other lesions, only one thing in the upper lobe. So if you see the nodule morphology, it is kind of speculate and there is some bronchus going into it. Size is 6 millimeter. It is a solid nodule. It is not a ground glass nodule. So that excludes atypical adenomatous hyperplasia for us. A spiculate solid nodule, yes. Invasive adenocarcinoma, 6 mm, right? Minimally invasive adenocarcinoma, adenocarcinoma in situ, metastasis, and of course, non-malignant lesions. Those are the differentials which we can consider in this patient. Okay, so that was the exercise to revise and see. In this kind of lesions, if it's more than 8 millimeter, then PET might help. But actually, in this, even though it is 6, it did show uptake, not growing. So the only way to see how this is progressing is following it up further and seeing whether it remains stable. The second case is a 81-year-old female who had a CA breast many years ago, which was treated with mastectomy. She has a chronic respiratory illness with occasional changes in saturation. And she has stable findings on multiple CT scans over 4 years. Forget the left lung changes. Just look at the right side lung and let me know what you think of. What is your finding and what can it be due to? Yeah, just look at the right lung findings. Or specifically, you could look at the right lower lobe findings and tell me what you think those could be. Right lower lobe. Any replies?
Yeah, we have lipidic predominant and RT related changes and Age-related changes.
Right. So what is the finding?
Lymphoma,
Which one?
lymphoma, lymphangitis, amiodarone, age-related, post-RT. These are all the options.
So what are the main findings in the right lower lobe specifically, which I told you? There are post-RT changes, I agree, left side and all those things. But the main findings in the right lower lobe is the presence of multiple ground glass attenuation nodules, which are around 5 millimeter, not more than that. Okay, so smaller or 5 meter, multiple 5 millimeter ground glass nodules, pure ground glass nodules. They are not solid in the right lower lobe, and these findings have remained stable for last 4 years. Actually, she had nodules like this throughout both lungs, both sides. So in this setting, stable ground glass nodules over 4 years, purely ground glass, no solid component, multiple, we have to consider the differentials, and she has a known primary. Metastasis, as I said, it's not going to be stable for 4 years like that, and it is not going to be pure ground glass like this, little unusual. Okay, so that is out of the question. So metastasis is out. What are the other things apart from inflection and all those things? But again, all this is stable over last 4 years. So pure ground glass nodules, as we discussed before in the context of cancer, can be atypical adenomatous hyperplasia, adenocarcinoma in situ, minimally invasive adenocarcinoma, or a lipidic predominant. But the minimally invasive and lipidic predominant, it can be very early, it can be like this. So but a multiplicity stable over 4 years, most likely it will be either multiple adenocarcinoma, I mean atypical adenomatous hyperplasia, or adenocarcinoma in situ. These are all indolent, and they take time, very long time to grow. That is why the follow up is sometimes over 4 to 5 years. They follow up the patients, and the whole point in following is up is if it's just pure ground glass, no issues. The development of a solid nodule warrants further evaluation. Okay, that is why we follow up all these ground glass nodules. Either it grows very rapidly, very fast, or if you develop a solid nodule within these ground glass areas, then it is worrisome. That is why in the lung cancer screening programs, you do follow these up for very long time, because they are indolent also. I do not have histopathological proof like for this, but I'm just doing a discussion and an approach based on what we have so far discussed. Last case, it's a 54-year-old female with copious frothy sputum production and cough.
Invasive mucinous is what people are replying.
Okay, so that's good. So what we are finding here is you can see there are areas of ground glass opacities, consolidation, air bronchograms happening, multifocal, diffusely involving both lungs. You can see a nodule which has kind of speculation, multiple small ground glass nodular areas also. So this is like a multifocal adenocarcinoma, probably a mucinous type. Imaging wise, that's something we can think. So this was actually a multiple, I think no, I think this was actually a adenocarcinoma, definitely yes, synchronous multiple.
I have one question about PET CT. Which ones will be PET negative, and like where should we be cautious about just using only PET?
Yeah, I didn't elaborate on that because of the patterns we were looking at, but I think the lipidic predominant ones will be PET negative. Most often they will not be showing up uptake on PET. So that is a problem. So even if there's a part solid nodule, I think sometimes the size matters. So if it is less than say 8 mm, then I think the recommendations say PET for nodules greater than 8 millimeter. So less than that, you might have a problem.
Yeah, so PET is not always like 100% thing. So we have to be aware that some of these early or minimally invasive or only in situ, such things can definitely be negative. So we like that is not always final resort. So final will be biopsy whenever we're having any doubts. One more question is about the carcinoma with that's in cystic air spaces. Is it like carcinoma developing in pre-existing cysts, or is it like that, like a pseudocavitation part of it?
No,
Did you comment?
one theory which I understood was which is most recommended theory is that it is more like the tumor is so small at the level of the alveolus initially, so it acts like a ball valve mechanism. So as the tumor slowly goes, it starts trapping air. So the tumor seems to be the first one rather than the cyst. Okay, so that is one theory which is most popularly advocated. So it acts like a ball valve mechanism rather than a pre-existing cyst which develops a complication. Though that is possible, scar carcinomas and so on things can happen. But this is a more favored theory that it acts like a ball valve and multiple, cysts form after the tumor starts.
Thanks for that. Yeah, I think when we see that, we'll try to say that it may be some old TB and such things.
Yeah,
No, so
yeah.
it's really
So
important to be aware of
at
that
least to
kind of
follow
entity.
them up. Follow them
Yes.
up. That is
Yes.
important.
Yeah. One more question that has been asked is about whether we can see pleural effusion in lymphomas.
Yes, you can, especially when it presents like a lymphangitis, because it produces obstruction and then pleural effusion. You can have direct pleural invasion, and you have what is known as a primary pleural lymphoma also. So all these can present with pleural effusion.
One more question. In a patient with known malignancy with multiple lung nodules, when clinician asks us about lung nodules for staging, what should we say? Should biopsy be considered?
You mean to say when it is at the same time? Is it like, yeah.
What I understood is known malignancy with multiple lung nodules.
Okay.
Basically, like I think what we are saying is, if for staging, should we? I mean, can we say it's metastasis, or do we need to biopsy each time?
Oh, I don't think for that we need to biopsy, no? If it is.
Yeah.
Yes, Aparna. Yeah.
Dr. Indu, am I correctly asking your question? You can probably, I don't know whether you can unmute, and I don't know whether I'm correctly interpreting your question.
So
yeah, I think when it is obviously like metastasis, we don't need to biopsy. If there is any doubt, it's always okay to biopsy. Whenever any kind of doubt prevails, it's always okay to biopsy.
Okay. I think the question is it a multifocal lung cancer or is it metastasis? That question, I think. So that will be the that will be the when will you think of multifocal cancer if there is a known primary? That might be the issue, I think. So if the pattern is different, then we could consider, like for instance, if the nodules are more ground glass clustered together, they don't have that round nice appearance, then it's more plural, I mean more peripheral, some different pattern, unlike a usual metastasis, then I think we can consider, can it be a second synchronous lung lesions or something? What do you think, Amparna?
Yeah, I think that is a good way to go about it. So if it is definite solid nodules, what we see typically, then I think we can take it as metastasis. And if any doubt prevails, definitely we can biopsy. Especially like Dr. Yvette said, any ground glass, any pseudocavitation, bigger areas of consolidation, then definitely we can think of that. And many times when this multifocal adenocarcinoma presents with that nodular form, most often there will be a dominant nodule. So there will be one big nodule, and then there is like this numerous tiny nodules diffusely. I think somebody wants to see that review case 1 again.
Oh, you want me to show that? Okay, 1 minute.
Yeah, one most important question is, should we try to say the possible type in our reports?
I don't think so. Like I mean, maybe the lipidic, and that's, I don't know how you do it in Vellore Appanna. Histopathological types.
Yeah, we are not really saying it. Although many times in our mind we keep thinking, yeah, this is
Can
likely
this
to be
be,
adeno
yeah.
when we are seeing all these kind of patterns. Yeah.
No, I think
So
basically because there
I
is
don't
so
know whether we
much
can raise that
overlap.
possibility maybe, but
There is so much overlap between lung cancer patterns and whether it is a cancer at all. So when it comes to imaging for us, we are stuck with that level itself for a very long time. That itself is so first it has to be proven. Some things are straightforward. Like if you see pseudo cavitation and all that, we can trace it. But a lot of times it becomes difficult. And extensive ground glass, maybe then we can trace. Is it something like that? But a lot of times we will not be able to mention the histological type. Small cell carcinoma, yes, you can raise the possibility. Squamous also you could.
yes, a small cell lymphoma, such things we can
We
definitely
can
raise the possibility.
But within
And,
adenocarcinoma.
yeah. Yes, difficult to say, and yeah, it's okay to say, but finally, definitely, we need the histopathology. So
this is the case one review. Somebody had asked for it. Is it okay? What was your question? Anything?
Oh, maybe that was the based on the question that like when there is a nodule in a known malignancy, how do we?
Oh, okay.
That is what the question. Okay. Now I understood. Yeah.